12 weeks gestation until the delivery. Who are the women who are at high risk of preeclampsia in ART group? Major risk factors are hypertensive diseases during a previous pregnancy, chronic kidney disease, autoimmune diseases, diabetes, and chronic hypertension. Women who have moderate risk are post pregnancy, maternal age more than 40 years, pregnancy interval more than 10 years, BMI more than 35 kilogram per square meter, family history of preeclampsia and multiple pregnancy. How do you clinically manage women in IVF with hypertension? Women with any of increased high risk factors, irrespective of whether they meet the criteria for prophylaxis, should also have a plan for closer maternal and fetal surveillance. At least every 3 weeks between 24 to 32nd week of gestation, increasing to every 2 weeks thereafter. Just bringing one case scenario here, which we recently dealt. 35 years, Mrs. KB. Her BMI was 26, known case of PCO. Previous two failed IVF, one with self and donor cycle, conceived with ovum donation. We did frozen thaw embryo blastocyst transfer. Counseling was done regarding expected problems, keeping in mind all high risk factor of PIH. Single pregnancy going very well till 24 weeks. Patient was from nearby town and she had one relative doctor in her family. She stopped coming to follow up. After one afternoon at 28 weeks, Mrs. KB called up developing swelling, advised to come for checkup, which appointment she missed again. After 48 hours, she came with full-blown severe preeclampsia. Urine protein 3 plus, 180, 120 blood pressure, swollen feet, hands and blurring of vision. Now our challenges here were severe prematurity, fetal growth restriction, severe preeclampsia, impending eclampsia, and bigger challenge was relatives were not agreeing for delivery because it is 28 weeks. Pregnancy is achieved after IVF and a long journey to IVF. But we really had to conceive that now she's going developing blindness and all the problems we have to deliver, otherwise we lose mother. So anyway, they agreed. It management, of course, is multidisciplinary. Physician was called, echo was done, ophthalmologist to see fundus. They diagnosed retinal detachment because of edema. All battery of investigations were planned. Antihypertensives were started. Took lot of counseling to deliver premature, severe preeclampsia. LSCS 1 kg baby girl delivered. She needed ventilatory support because and stayed in NICU for 45 days with ups and downs. She was discharged home. Point I want to highlight here is we had no time to give steroids because patient didn't come for follow up. Good neonatal support system we could sail through. So I think it is very, very important that a woman like this should follow the advice, and the doctor relative who is there. I don't know whether the doctor was advising her regarding, like her blood pressure management or whatever, but telephonic consultation has to be limited, especially in these cases who are at high risk. I mean, every case, but especially in these cases. So the things probably would have been different if patient had kept her appointments. PIH could have been picked up early and antihypertensive started, and maybe steroids could have been given, which would have shortened stay in NICU. Like how to manage the problems. Can we really prevent the problems from happening? Maybe yes, by educating patients, relatives, and caregivers, because not all IVF patients will deliver at the place where they had a IVF. So, where if they are going to periphery, so I think by through the webinars or by updating people, we can really educate the caregivers. And if they present with problem, we need to talk about the solutions. Now let's move on to the GDM. Whether or not ART increases the risk of GDM is controversial, with some studies reporting an increased risk and others not. The prevalence of GDM is twice as high among women with PCOS than among without PCOS. So we should consider offering screening for GDM to women who have been diagnosed as having PCOS before pregnancy. Venous thromboembolism has been shown to double the risk of VT during pregnancy in the absence of any other risk factors. However, prophylactic anticoagulants with low molecular weight heparin is not required. Let's look at the fetal complications. On a regular basis, when we counsel for IVF, we are being asked this question, doctor, will my baby be normal? Because still there is a myth that the babies conceived with IVF may not be normal. Over the years, as more pregnancies have occurred and outcomes have been reported, much of this fear has been abated. With confidence, now we can counsel our IVF couples. While some complications are still more common in fetuses arising as a consequences of ART, fetal genetic and chromosomal disorders and structural anomalies, there are studies, but not all, suggest that congenital abnormalities are more common in children conceived following Aicc than standard IVF. Despite the reported 34 to 40, 30 to 40% increased incidence of fetal structural abnormalities observed in individuals undergoing ART, the absolute risk is very low, 6.5 to 7% versus 5%. So, points to be taken into consideration: women with assisted conception should be offered antenatal screening, such as first trimester combined test, anti maternal serum biochemistry. However, numerous studies have demonstrated that ART is associated with changes in biochemical serum screening markers, such as pregnancy associated plasma protein A and human chorionic gonadotrophin. So, a few studies have even shown that NT measurements may also be affected by type of conception. So it is also worth remembering that if donor eggs are used, the egg of donor should be used to calculate the a priori age related risk, not the age of women undergoing the treatment. That's a very important point. Fetal growth restriction, the cause of fertility, may account for more of the variation in birth weight than the mode of conception. Stillbirth, there is some evidence that compared with spontaneous conception, assisted conception are at increased risk of stillbirth. And, however, determining to what extent ART procedures themselves are responsible for this is a complex. That stillbirth rates appear to be increased in women with a history of subfertility, regardless of whether ART is utilized. And there are still, there are higher rates of ART uses in women who have previously experienced a stillbirth. So you cannot really directly extrapolate that ART increases the stillbirth. Timing and mode of delivery, some clinicians feel that because of the higher stillbirth rates observed in assisted conception, induction of labor at term should be considered. On the other hand, there is little evidence that this practice increases interventions such as emergency cesarean section. Preterm labor, we know that pregnancy conceived with ART following ART are at increased risk of preterm labor because there can be multiple pregnancy. Again, it is difficult to retrospectively distinguish between spontaneous and iatrogenic causes of preterm labor. Placental complication, some interesting facts. A recent systematic review and a meta-analysis concluded that singleton pregnancies conceived using ART are associated with a significantly higher risk of placental anomalies, including placenta previa. Compared with spontaneous conception, there is a higher incidence of clinically significant placenta previa persisting until term in assisted conception, particularly those that have involved the transfer of a blastocyst rather than a cleavage stage embryo. This is for the IVF specialist. And just to mention on the papers that it was a blastocyst transfer or it was a 8-cell stage transfer. So assisted conception occurring following transfer of cryopreserved rather than fresh embryo are less likely to be complicated by placenta previa. So these are the certain interesting facts. Vasa previa again are more common in assisted conception. Just to conclude my talk, have a balanced worry. We always, as a IVF practitioner, infertility practitioner, or even an obstetrician who are giving care to pregnant women who have conceived on ART, we are sometimes over worried and we try to take decisions. Sometimes decisions may be like, like a preterm can happen and fetal growth restriction thing. So while most assisted conceptions have a normal course, not all do. So elective transfer of a single embryo reduces many risks, but even singleton pregnancies resulting from ART are at increased risk of some maternal and fetal complications. And awareness of this risk is mostly all that is required, and assisted conception should be managed in the same way as spontaneous pregnancy. A thorough risk assessment is imperative. Since many women undergoing ART have additional risk factors that necessitates increased monitoring, still in our country, IVF is considered as a stigma, and not many couple will tell you it is an ART pregnancy. In history, make a point to ask spontaneous conception or assisted conception. May not necessary that you write IVF, just make assisted conception. Make a note of high risk pointers or put a red flag. Date of embryo transfer is important to be mentioned, as calculations for biochemical markers to be based on embryo transfer, that not on the CRL, and age of donor to be put in form of biochemical screening. So just to summarize, use of ART to achieve conception is increasing worldwide. 1 to 5% of babies born are from ART. Majority of resulting pregnancies will have a normal outcome, not all do. Assisted conceptions are at increased risk of maternal and fetal complications. Healthcare professionals involved in antenatal care of women who have conceived using ART must understand the potential risks, their significance, and how best to monitor them. And most important thing, must counsel couples before and during IVF treatment about the potential problems. You have to continuously at every visit, you have to emphasize that what are the risks they can have, and especially before you are registering them for IVF, it is important to tell them about the potential problem. So thank you very much for the patients listening.
Thank you very much, Archana. I'm stepping in on behalf of your chairpersons because some emergency and they were unable to stay on. So thank you. And as a generalist, as a general obstetrician, it was was really hoping to learn a lot from this webinar, since I don't have much knowledge or interest in infertility. So thank you for such a lucid presentation, and in which you have clearly brought out how IVF or any assisted reproductive techniques do make the woman at high risk of various maternal as well as neonatal complications, particularly because many of them are slightly older with several comorbidities. So this really complicates the issue. Your case, I'm sure all of us have come across women like this who, we know that something is going to happen. We have a gut feel that things are not really, and however much we counsel them, they miss appointments, and they take advice from people who are either have never seen them or are far away and so are not able to give the right advice. But from your take home messages, what I found very interesting was your slide about cryopreserved embryos actually having less chance of, less chance of placenta previa, because that is something which now, with more and more cesareans, particularly in the IVF pregnancies, we're all so worried about placenta previa and placenta accreta spectrum. So thank you so much for telling us about all these things. And now, as far as preterm labor is concerned, I would like to really reiterate to everyone listening that steroids we all remember, but many of us still forget the Magself for neuroprotection because it's something which has started a little later. So do think in terms of Magself also. And I'm so happy that Archana said that LMWH is not required for all these women, because as generalists, I'm sure many general obstetricians will see that we often see prescriptions with heparin, and we can't understand why. And then we are told that it is probably for the immunomodulating effect. If it is for immunomodulation, I would suggest that, perhaps it has to be used in the regular dose, because we see it being given twice a week or on alternate days, and I really don't know whether there's enough data to suggest that it will immunomodulate at that rate. I'm sure many of these things will come out in the panel that Rupali is going to moderate soon. So I will just thank Archana once more on behalf of all of us here. And that message about the donor age being used, donor egg, the age of that person is important, because a form is often not filled out by a clinician. It is just, we just write, quadruple test or first trimester screen, and we send it off, and the form is not filled properly. So even the fact that it is an ART conception should be mentioned on the form, even if it's not a donor egg. Thank you very much, Archana.
Thank you, Jyoti, for your comments. I really am happy that I changed the subject so that even the general gynecs would interest them. So over to Akriti and Ditya to hand over it to Rupali for panel moderation. Thank you, Jyoti, for taking over and really giving us very good insight.
Thank you, ma'am. This was a very insightful and informative session. And thank you, Jyoti, ma'am, for concluding her in a very short notice. Thank you so much, ma'am. Uh, so, we'll continue for the next part of our session, that is panel discussion. And the moderator of the panel discussion is Dr. Rupali, ma'am, and Dr. Sharayu Mirji, ma'am. Sharayu ma'am has done her fellowship in oncology, and she is currently doing her private practice in Mumbai. And we have already introduced Dr. Rupali ma'am, who is convener of the session as well. Rupali ma'am has done a fellowship in infertility. She is consultant in Surya Hospital, Mumbai, Critic Care Hospital, Mumbai, and she is having special interest in IVF and infertility. Over to you, ma'am.
Thank you, Akriti. Thank you very much. Thank you, everyone. Dr. Archana, ma'am, it was really a nice talk. And I think it was, as you said, it was good that we changed the topic because there would be a big overlap. So we move on. Our topic today, just I hope, can you see the slide?
Yes, ma'am.
Yeah, so today we are, without wasting time, we are going to have a panel discussion today, and we will be discussing on the dilemmas which we come across as general gynecologists or as infertility specialists as well when we come to diagnosing PCO patients in the first place, then investigating them and taking things forward. So we have a couple of 2-3 cases lined up, but before that, we would like to just go through the basics of PCO, not wasting a lot of time. Yes, Sharayu, can you take over?
I thank you so much for this platform. I think let's start with introducing the panelists first. Uh, first, let me introduce Dr. Rachna Dubey, who is the
Uh,
director.
yeah,
We have
Sharayu.
a slide also.
No,
Uh,
Sharayu, Dr. Rachana ma'am is not,
there.
she's
Okay,
traveling. So a couple of
okay,
panelists are not on board because they are either traveling or they are stuck up in some emergencies. So as of
okay.
now, the panelists who are there are Dr. Sulbha Arora, Dr. Siddesh Iyer, then Dr. Jyoti Karande ma'am, and I think Dr. Rachna and Dr. Shashank Shekhar. Yes, these 4 doctors are there. So we'll go to introduce them first.
Okay.
Can I have this introduction slides, please? Sudeep?
Yes, madam. Can you see the slide?
No.
No.
Rupali, you will have to stop sharing your screen so that
I
he
will
can
stop.
share.
I will stop it. Yes.
Yeah.
Sandhya ma'am is also not yet joined. She had some family emergency.
Ma'am, she is going to join in 5 minutes.
Yes, she will join. As soon as she joins, we'll introduce her. So we have Dr. Shashank Shekhar sir with us. He is the professor and unit head, and he's a coordinator of fellowship in minimally invasive gynecology. He also has the IGCS Gynac Onco Fellowship from the University College of London. He's attached to AIMS Rajasthan. So, and the next is We have Sudeep, Dr. Siddesh.
Next one.
Dr. Kavita is also not there with us today. She has an emergency to attend. Can we have
Yeah,
Dr.
I am there, but I have logged in with other this thing.
Okay, so
Hmm.
Dr. Kavita, hi. If you're there, I'm
Hi.
we're so glad that you are here.
I didn't get the link, so I had logged in through Ditya's link.
Okay, sorry.
Yeah.
So, Dr. Kavita Ghadekar, we're very happy to have you on board today. And she's very active in Nashik. She's been the secretary of IMA Nashik. She's consultant and director at the Dr. Ghadekar Maternity Home. She is having her specialty in managing sonography, PCOS, fertility, adolescent, and menopausal health. She has a lot of accolades and achievements at her end as well. We can have the next panelist, Dr. Siddesh. Shreya has also not joined. Yes, Dr. Sharayu, can you introduce Dr. Sulba?
Yes, Dr. Sulba Arora, who is the clinical director of Nova IVF Mumbai. We all know her through that. And she has a lot of publications and awards to her credit. Uh, the next one.
Good evening, everyone. Thank you for the introduction.
Thank you.
Then we have Dr. Siddesh. Yes, Dr. Sharayu, please introduce.
Dr. Siddesh, who is a consultant obstetrician and gynecologist and a laparoscopic surgeon. He's the director of Saukhyam Hospital in Mumbai and Borivali. And he's also a dear friend. Welcome to the panel, Siddesh. He's a man. He's also a managing committee member of MOGS, and he's been a very active MOGS member since many years.
We can have Dr. Jyoti Karande, ma'am, CV, please. Yes. Dr. Jyoti Karande, ma'am, is the vice president of the Indore OBGY Society. She's the examiner for MRCOG Part 3. She's been the joint secretary of AICOG 2022. And she's an ex-consultant of Manipal Hospital. I know Jyoti Karande, ma'am, and she's got a real good storehouse of knowledge. So we're going to have a good interaction and a lot of take-home messages from her as well. I think these are all the panelists which we have on board today. So we will start with the panel discussion. And as Dr. Sadhya Saran and all join, please do tell us, Sudeep, so we can introduce ma'am. Yes?
Yes.
Are the slides visible?
Yes.
Yeah.
Rupali, slides are visible.
Yes, thank you.
Okay,
Yes.
so before we go on to discuss the three cases that we have, we just thought we would do a quick discussion about PCOS and related infertility. So the latest updates in the PCO guidelines that have come up in 2023. So next slide. So first, I would like to ask Dr. Siddesh, maybe, what are the criteria that we use now to diagnose PCOS?
Dr. Siddesh Iyer.
Next one.
We have Dr. Siddesh Iyer, right?
Yes, ma'am. Yes, ma'am. We have Dr. Siddesh.
Yeah, but then anyone can take this.
Anybody can take the question, just the basic.
Hello.
Hi, Siddesh, you're there?
Yeah, this is Dr. Shashank.
Shashank, sir, can you please take this question? What are the criteria to diagnose a PCOS?
Yeah, so as of now, it's the Rotterdam criteria, NIS 2012 consensus conference. And I think that's what's followed mostly across the globe, Rotterdam criteria. And you have to have 2 out of 3 present. The criteria are oligomenorrhea or menstrual disturbance, or hyperandrogenism, either biochemical or clinical, or polycystic ovarian morphology. And based on the combination, you can have 4 phenotypes: type A, type B, C, and D, in different combination and permutation of these 3 criteria.
Yes, and now according to the new guidelines, the only thing they've added is that we can actually use AMH also as an alternative to the polycystic morphology. That is something that they have added now, but otherwise the same criteria. So Just if somebody can talk a little bit about the ovarian morphology in PCO, because that is one of the very important diagnostic criteria as well. Uh,
So with advancement of ultrasound machine, previously it was like 10 follicles per ovary, but now it has been increased to 12 follicles per ovary. Either any ovary, if it has more than 20 follicles per ovary on a TVS scan, or if you do not have a TVS scan, you are doing an abdominal, then if you take a cross section, you should have at least, if you have more than 10 at any cross section of the ovary, or volume of the ovary is more than 10 cc, if these criteria are fulfilled. But the first one is the best. If you have a good machine, if you have a transvaginal probe, and if you have more than 20 follicles in one antral follicles of 2 to 9 millimeter in any one ovary, that fits the criteria for polycystic morphology. Besides that, you will have increased stroma, increased echogenicity of the stroma, increased area of stroma as compared to the area of ovary, and volume of stroma to volume of ovary will be more than 75%. But these are not essential criteria for diagnosis.
Yes, and that is one of those features which can help us to distinguish between other kinds of cysts in the ovary, which may be functional or pathological, but the stroma is maintained in those, unlike what happens in PCO. So the next question would be if a patient who is already diagnosed with PCOS and now she's facing infertility comes to the OPD, what investigations would be should be ordered? How should we go about investigating this patient? Anyone,
Should
Dr.
I?
Sulba?
Yeah.
Yeah.
Okay. So apart from routine investigations, we would also do for some of the hormonal studies in these patients. For hyperandrogenism, we would do the free testosterone levels, and thyroid and prolactin, we do it as a routine in all the infertility patients. Fasting insulin, 12-hour fasting insulin is also advised in these cases. And if these patients are insulin resistant, we definitely go ahead with OGTT, 75 gram of WHO testing for sugars. So these are the tests which are preferred. Most of the hyperandrogenism we preferably avoid except for the free testosterone. Unless and until if it is going towards CH, we would go ahead with DHEAs and androstenediones.
But do we
Dr.
all,
Sandhya here.
for
Hi.
all patients who walk in with a PCO, would how important do we now, like before, we some years back we used to always do the fasting insulin level. So how important is doing fasting insulin and these levels?
Most of the patients would rather have acanthosis nigricans. Clinically, we can directly start the metformin looking at the acanthosis nigricans and obesity. But I prefer having a baseline insulin because even the levels help them to even many of them are reluctant to take metformin because it is a diabetic drug. So a report in hand always proves that you need metformin. It is only for patients' convenience. Most of the clinical diagnosis we don't need fasting insulin. But as a routine, I do advise fasting insulin. Some patients would have rather have normal fasting insulin, but they would have symptoms, signs of insulin resistance, clinical signs. There also, again, counseling is needed, and we can start metformin in those cases. I think it's more of a record purpose, but it is always better to document it.
I am not an IVF specialist, so I don't go for fasting insulin in all patients. 2 hours OGTT or fasting glucose or HbA1c if patient comes. And of course, waist ratio, diameter, and all basic parameters, other parameters we to keep a baseline. Even if patient is having a family history of cardiovascular disease or anything, we can do a lipid profile also, blood pressure measurement to keep it as a baseline.
Okay. Okay. Anyone has a difference of opinion here so far as a fasting insulin or levels are done? Dr. Sulba?
To do
Yeah.
fasting several years back, but after the PCOS guidelines came out in 2018 and the newer ones in 2023, both seem to suggest that it is not really of much significance because sometimes it does not pick up hyperinsulinemia as well. So I don't do it any longer in most cases. In fact, like you said, if a woman with known PCOS walks into my OPD, I would also like to know the semen analysis and the tubal patency before deciding what kind of treatment options should be offered to her. thyroid and prolactin, yes, of course, that should be done. And for all patients with PCOS, some kind of blood sugar monitoring, either with a fasting OGTT, HbA1c, or a lipid profile. A lot of times we find that women are unnecessarily investigated way into depth without even one semen analysis being done. Sometimes it is reluctance on the part of the male partner, but it's very important to counsel them that in almost 40% cases, there's a combined male factor as well. So that should in fact be part of the initial investigation itself, rather than assuming that this is only PCOS and no other factor.
Yes. Thank you very much.
Excuse me. Yeah, Dr. Sandhya here. Can I make a point, please?
Yes, ma'am. We are waiting for you.
Yeah. I joined in a little
So that,
late.
let me just
Yeah.
introduce Dr. Sandhya Saran, ma'am. She doesn't need an introduction. She's the most vibrant and vivacious gynecologist I've ever met, with adorning many hats. So she's the past president of the Thane OBGY Society, and she's an honorary joint secretary of the PCOS Society as well. She is a chairperson of the AMOG's Midlife Committee, and she has got many accolades and awards to her credit. We're very happy to have you, ma'am, here. So we would like to really have your inputs on this as well.
Thank you so much, Rupali. Thank you for inviting me, first of all. I'd just like to make one point, like Dr. Sulba has absolutely enumerated that, the recent PCO guidelines, we definitely do not look into either the testosterone levels or the insulin levels per se. But now the BMI has come into, the BMI is considered as to a very important marker along with the AMH and the AFC. So these are the three ones which we say are very important for any patient with infertility. And we, Dr. Kavita said, if there is evidence of acanthosis, then you know that the patient has hyperinsulinemia and you have to treat accordingly. But if you feel that you want to do a baseline, only then you do a insulin level. Otherwise, not really required. OGTT definitely yes.
Correct. So
if I can just add a point here, the cases where I do land up doing a fasting insulin, because in my practice as an IVF specialist, I'm seeing a lot of women who are in the late 30s and early 40s giving me a history that they have been diagnosed with PCOS in the past, but this can no longer be picked up by seeing the ovarian morphology on ultrasound, because with age, the ovaries have become smaller, they've shrunken, they don't typically look polycystic. Neither is she says sometimes I have irregular menses, sometimes I don't, and the BMI is not more than 25. And I'm wondering if she would still benefit from metformin. I think those are the select cases where I might still do a fasting insulin, but not generally for all PCOS patients.
Yes, thank you very much. Sharayu, next.
Yeah. So now we have diagnosed and we are going to start treatment. Of course, most PCO patients are going to need ovulation induction. What are the markers that can help us predict how she will respond to ovulation induction? Anybody can take this?
Siddesh Iyer is there. I think he had joined. Anyways, Dr. Shashank, Dr. Shashank, can you take this question, please? What are the predictive markers?
The predictive markers of for ovulation induction, which can help us decide.
Yeah. Which you're saying what would be the predictive markers, clinical or biochemical, which will predict ovulation induction in a case of
the response to that. Yeah.
Yeah. So it would be age. If we go historically, it would be her age, BMI. Obesity itself independently is associated with with ovulatory rates, and it would be, if there are other insulin resistant marker clinically present, it could be, if we speak about biochemically, LH, if she's LH hypersecreted, that would be another biochemical marker. And I think this is important. And if she has taken any previous treatment for ovulation induction, what had been her response with that would also be important. I'm not so sure about AMH as per se, but AFC counts. AMH, if she's advanced stage, that would also be important.
Yes.
So while I was just reading up on this topic, I came across this index, ovarian response prediction index, where they are taking, they are multiplying the AMH with the antral follicle count, and dividing it by age. And according to one study, this can be a very useful marker to predict what will be the response, and maybe it can be used while deciding the protocols. I think let's move on to the cases now.
This was just an overview which we had about, the basics. We didn't try to go into the depth of PCOS because we would like to concentrate more on the practical aspects of how would we manage right from a small mild PCOS case to as well as, a PCOS who is going in for an IVF or an ICSI. So this first case, Dr. Sharayu, can you take it?
So she is a 33-year-old patient, married since 3 years, nulliparous. She's been trying to conceive since 1 year. She has a typical history of irregular periods, mild acne with hirsutism. Her BMI is 28. The investigations, she has already been investigated by a doctor. The basic investigations are shown here. The semen analysis and the HSG are normal. PCO morphology is seen on the sonography. I would like to ask, first of all, as we all know, the first would be lifestyle management and weight reduction. Can anybody talk about what specific advice we should give for weight reduction and lifestyle changes for these kind of patients?
So I can take this, Dr. Sandhya here. Is it okay?
Yes,
ma'am.
of course.
So yeah, since I do a lot of lifestyle modification proponent, so see what happens is patients, first of all, they do understand that they do have a problem, okay, but it is very difficult for them to implement. So it is something like, we say cognitive behavioral therapy. So it is very important to explain to them that they need to set certain goals for themselves. Now, if they are going to look at, infertility, or if they are going to look at anything which is, in the near future, so they have to understand that everything has to be optimal. So you have to explain to them what are the problems that they can encounter if they get pregnant, first of all, and what is the timeline. Sometimes it takes almost 1 to 3 years for them to even get a good ovulation done. So these are the things which you have to, goal setting is very important, and, reinforcing their own, motivating them, that is very important. Then you tell them exactly how it goes, what kind of an exercise pattern, whether it is 150 minutes per week of rigorous exercise, or if it is 50 minutes per week of moderate to, this intense exercise. So that is one thing. And 5% reduction in weight can also help in, resumption of normal cycles, or even ovulation to a certain extent within 3 to 6 months. So that is how you give them small steps, at a time. First, you start with this. And all these fat diets, like, I say, it's not very easy to tell them, okay, you go on a once a meal, one day, once a day meal, or you go on to Dixit diet, or these things. They don't say caloric restriction is the main important thing, whether it is intermittent fasting or whatever. Caloric restriction is most important. And of course, cutting down on the kind of foods, increase in the proteins, and reduction in fats and carbohydrates. So I think when you give them small goals, and, keep motivating them, keep asking them to follow up, keep measuring. And there is nothing like a cheat day. You can't say, you will fast for 5 days, or you will follow for 5 days, and 2 days, weekends I go out, I eat. No. So you have to keep reinforcing what is the.
So we can give them realistic
With
goals.
so many years working with people, I'm not an IVF specialist. I'm a general practitioner. First, they will come to us. Whatever I realize that they know exactly that they have to reduce weight and eat healthy, but we have to go in very detail of their daily routine. What time they get up, what do they eat, exactly what is happening in their life. Every person has different problems and different eating patterns, different work patterns, and then find out there what can be managed in their life. So give a very individualized plan. In general, they know what to do, but exactly in lunch you take this, in dinner you take this, you have in between your lunchtime take 1,000 steps up and down in your office. If they are doing office work, go on a don't take a vehicle for your office, take steps to your office. Like small things we have to take and tell them in their daily routine what to implement, so that they achieve a 5 to 10% weight loss. And then, as Dr. Sharon said, you have to give them smart goals so that they can achieve, and then whatever they are achieving, we have to be happy with them and encourage them that they go on, keep on pushing them to do it. And those who will listen will definitely find advantage of this.
Yes, yes.
Yeah,
Very
I would also like to add, I'm Dr. Rachna Dubey, although I'm traveling, but
yes.
I would not be visible. Having treated more than 6,000 patients for PCOs because I am the state in charge for the PCO clinic. What I have found, I totally agree with Dr. Jyoti that we have to give them small steps and we have to keep monitoring because these patients usually falter and they get demotivated after a period of time and then they realize that they're not losing on their weight, so they stop following the treatment. So it is important that when we are taking this case, we have to, our assistant or our anthropometric measurements, whosoever assistant is doing it, she should keep on checking with the waist hip ratio, her waist ratio, her neck circumference, whether she's coming down with her inches or not. If that she's following, then she should be motivated that yes, she's moving the right direction. And I also agree with them that I usually put my patients, usually Indian diet does not contain more than 8% of the protein calories coming from the protein. So I tell them to at least increase protein intake in every meal that they are taking. So then in that way, basically they would reach to somewhere around 18 to 20%. So that is what will help them to make their muscles and lose weight.
Yes, ma'am. Thank you so much. That
Yeah,
was
I would like to add a point over here. Sometimes these patients are depressed. How much ever knowledge we impart them, it doesn't penetrate them. So this certain cases will require holistic approach. A psychiatrist or a psychologist involvement is essential in such cases.
yes. So a multidisciplinary team of doctors, if we involve, we probably if we could have PCOS clinic in the coming future, where we have an endocrinologist, a gynecologist, a dietitian, and exercise, everyone together sitting in one clinic. And one whole day we devote to only PCOS patients. I think the growing population of PCOS, we're soon going to have these PCOS clinics blooming everywhere, where we can, as Dr. Kavita rightly said, we can give them a holistic approach and the complete care under one roof. Very true. Any idea on the anti-obesity drugs which are in market? Dr. Sulba, you're into an IVF practice. Do you advocate this? And also, I would like you to have a word on the bariatric surgeries if any patients you have come across. What would be your advice be?
We don't advocate it as the first line of management. Definitely, it starts with the lifestyle, just as all the other panelists have very rightly said. We start with giving them advice about diet and exercise. And also, we explain to them that metformin will help with the weight loss. That motivates a lot of them to take it. But some of them are very, very resistant. And though I'm not, an anti-obesity specialist, I do, then prefer multidisciplinary management where I would rather take the opinion of somebody who does treat obesity per se. And yes, there are drugs now, especially the liraglutide, semaglutide. A lot of people are on them. They are FDA approved for management of obesity for women whose BMI is more than 30 or women whose BMI is more than 25, along with a comorbidity such as diabetes or hypertension. They are some of them are expensive, some of them are sold off label in India, not really available there. So they are not really so common, but I do know a lot of people who are taking them. Bariatric surgery, yes, that would be reserved for people with a very, very high BMI. I have seen women whose BMI is in excess of 60 kilogram per meter square, not getting any younger. In such cases, after doing all the investigations and taking the fitness, we have gone ahead with at least doing an egg retrieval. But I have told them that freeze the embryos, don't actually go ahead with the pregnancy till you have managed to bring your BMI down. And this is the select category of patients in whom no amount of lifestyle modification might help, and they may need bariatric surgery because this is too high a BMI to come down with lifestyle modification alone.
Yes.
Dr.
Well,
Rupali, I'll just make a point.
yes.
Like you said, the PCO clinic. So we do have one at Jupiter where we have this multidisciplinary team, and we do have a half a day dedicated to PCOS where we do have a bariatric surgery team also. So of late, what we are seeing is yes, semaglutides, a lot of people are giving, and the endocrinologist also believes in giving it, but then it is always under supervision because there are too many adverse reports sometimes coming in, so it's something which has to be given under constant scrutiny. And also about the bariatric surgery, we've crossed almost 500 at our center, and we have young women who are like having a BMI of say 40, and they are not getting any better. And there is always a rush, that doctor, how long can I wait? Nothing is going to happen. So in those cases, when we feel that the metabolic syndrome is setting in, when the lifestyle changes are not happening, pharmacological treatment is not happening, or they're not motivated, we do offer them bariatric surgery. But then, yes, for 1 year, they have to wait. There is a lot of nutritional therapy involved, and only then they can get pregnant. But we've had 5 cases who gotten pregnant after 1 year
Wow.
in the recent last 1 year.
Yes, that is very nice. And we're moving forward to the next question. Dr. Kavita, can you take this? Dr. Sharayu?
So we would like to talk a little bit about the first line ovulation induction in these patients, where we talk about clomiphene or letrozole, and what helps you to choose, and what is your first drug of choice for ovulation induction.
Ovulation, clear cut. I think it's the favorite drug of gynecologist is letrozole. It's the first line of treatment for all the infertility patient, or as the first line in infertility patient with PCOS. Letrozole, it is an aromatase inhibitor. It helps to induce the ovulation. So the ovulation rate, the pregnancy rate, and the cumulative live birth rate is more with letrozole as compared to CC or gonadotropins, and the side effects compared to CC are much lesser, which is the thinning of endometrium and the cervical mucus. It is not hampered with letrozole. So, and also it's a safe drug, that the incidence of multiple pregnancy OHSS is less with letrozole.
Yes. So we can see that clomiphene can also be used in some obese patients where the BMI is more than 30 kg and they have anovulatory infertility. So sometimes these clomiphene can also be used. But as you rightly said, letrose is darling drug. So when we were just we came across this two fertile sterility, two studies which were done, and there was a comparison of two groups which was done, and one which was having a 2.5 mg, which was given for a standard 5 days, and the other was a 5 milligram dose which was given for 10 days. And they found that the 5 milligram for 10 days had a better ovulation rate as well as a pregnancy rate. Another one studies which was done was a step up regimen for all those patients who had a letrose resistance. So one group was given a 5 milligrams and the other was given 5 milligram for an extended period. So this extended period, whoever was given, definitely showed a better ovulation rate. So, Dr. Sulba, in your opinion, do you think that this extended letrose treatment, say for 5 milligram for 10 days, or does it really work more better for ovulation rates or pregnancy rates are concerned?
No, I had tried it in a few patients, but I did not find that the extended or the step up, the stair step regimens really helped. I do prefer to start with a dose of 5, not 2.5 mg, because 2.5 mg was used for breast cancer patients. Initially, they found out that non-anovulatory women started ovulating on it, and that's how they extrapolated it to anovulatory infertility. But as far as anovulatory infertility is concerned, it's been shown that 5 milligram is a better starting dose. You will have less cases of resistance to it. But if my patients don't respond to 5 mg of letrozole for 5 days, then I prefer to add gonadotropins from day 6 onwards rather than giving extended protocols.
Exactly. That is what was the great take home message for everyone, that please do not extend it for 10 days because it doesn't really have a great, that's what even I saw in my practice as well. So I wanted it from you. Next would be Dr. Rachana ma'am, if she could take over this question.
I had 1 or 2 patients where I had put them on a step up regime, starting with 5 milligrams and then 5, 7.5, 10, and then 10 for a period of 5 days. And somehow or the other, I was very happy with that regime, but it was only 2, 3 patients where I tried this, and I got a positive result in that patient. So this was what I did not add a gonadotropin, but in this case, I did a step up protocol of letrozole, and I was happy with it.
There is a role for
cases, yeah.
Especially, in patients who are not very affording, because we know gonadotropins really increases the cost. For patients who are as of now not willing for an IUI. In planned relation cycles, I don't add gonadotropins because in planned relation cycles, no matter what you do, your person Says rate, we don't expect it to be more than about 10% or so. Why make it so expensive that they, exhaust their resources in just that? So in planned relation cycles, we might give an extended letrozole protocol, or maybe instead of letrozole, try clomiphene, probably along with metformin and gonadotropins. I would add only if they were at least going in for an IUI in that cycle.
Very, very, very true and
Yeah.
very rightly said. Yes, Shari.
Yes. Dr. Rachna, can you tell us a little bit more about the role of metformin in this setting? How will
Usually, we are treating more of PCO cases were coming to us. So in PCOS obese patients, we are using metformin along with letrozole, and so they give better results rather than giving just clomiphene or letrozole alone. So metformin with in some patients with myonistal also, we are combining the two drugs. And if they are not obese and they are anovulatory, then only myonistal we are adding along with letrozole.
Yes, especially if somebody who's not looking for a pregnancy, not looking to conceive in the immediate future and has some time, maybe metformin will be even more useful
Metformin,
because it.
otherwise also, even if she's planning in a period of 6 months, in the we see metformin is not a contraindication now in the first trimester of
Yes.
pregnancy. So we are giving metformin, and we are continuing it even after she conceives.
So so like, metformin kind of the response is very gradual and not immediate. So 6 months, you can put the patient on metformin, and meanwhile she just has a regular ovulation and she may conceive spontaneously as well.
Absolutely, absolutely.
Yes.
And when we add metformin, they get a very positive feedback that they have to control their diet, they have to control their sugar, they have got a metabolic reason for their PCOS and infertility. So that way, मुझे sugar की गोली शुरू हो गई है, that gives a like apart from pharmacological effect of metformin, there's also a lot of psychological effect, and it gives a lot of benefit.
Yes.
Absolutely.
Yeah. So we move on to a second case, Dr. Sharayu.
Yeah. So the second case is a 35-year-old patient who's married since 5. She has had one spontaneous conception 2 years back, but that ended up in a miscarriage. She's a diagnosed case of PCO with a BMI of 29. AMH is 7. The other investigations are okay. AFC is okay. Semen analysis is normal. Tubes are patent. She has already tried all the first line treatment modalities, weight reduction, metformin, diet. Now she has come to you. Dr. Sandhya, ovulation induction she'll definitely need. Would you prefer directly going for IUI, or maybe just try ovulation induction with planned relations initially?
See, first of all, her BMI is 29. So that is definitely high. So I would say
After
if she
Sure,
is doing
madam, she
so
has
many
already
things,
tried weight reduction, metformin diet. All
No,
her is done. Now we're
yeah,
coming to the,
no.
book.
yeah.
Yeah.
Yeah, if she's done everything and in spite of that, her AMH is still high, her BMI is still high. So then it looks that it is going to be difficult to have any good results with ovulation induction also. So I would definitely start her on the metformin letrozole combination and then see if we are managing to get a good ovulation induction. If it is not happening, then I think we will definitely start, with again gonadotropins. We'll have to keep adding because we need results.
Yes, ma'am. The question
We
is
will,
one,
we,
whether
we
you
should,
would like
we
to go
should
for
give
an IUI or a planned relation.
IUI
So in
should be
this case,
preferred in this such a
IUI,
case. Yeah.
because we cannot wait for that long. Planned
Yeah. She's
relations and
already
again,
35
yeah,
years.
yes,
yeah.
right.
So that will waste time. So when we are going in for so many things, then definitely it has to be IUI. And I would also say that I would not do more than 3 or 4 IUIs in her case. If it is not happening, then I would tell her that we need to relook at, or we need to go to the next step.
Okay. So
I
next,
would,
yes, Dr. Shashank.
Yes.
yeah, I'm not an IVF expert and I don't practice a lot of infertility, but whatever basic, my field is different. But this, she's 35, her AMH is 7. I don't think so. There is anything to suggest that she has decreased over in reserves. She's not touched 36. All that she has tried is weight reduction. I think I didn't, and she hasn't tried any ovulation induction so far. Why not give her a trial of just search just letrozole straight away going to IUI? Cost is there. There are so many things, and the letrozole with planned relations. Why not? Why not three
Exactly. This is
cycles?
the dilemma
Why not
which I
three
wanted
cycles?
to.
I mean, how
This is
much
what
difference
I
would
wanted
it make? Just 3 months. Whereas if we look at the cost, and can we apply it to the every patient then? Does it become a protocol for every patient with same profile? I don't think so.
Here, I think we can offer the patients
Offer
because
both the
there is
options.
nothing which is like black and white. So this is the dilemma. What would we do in such
So I
cases?
would go
So
for letrozole, 3 cycles, at least 5, 2.55, 7.5. She doesn't conceive, I'll think about IUI
So if
definitely.
we can offer the patient and where money is not a problem, we can definitely go ahead and do an IUI if they want a quick conception. And those who are ready to wait, we can, give them the option of, as Dr. Shashank said, that, wait for 3 months and then move things forward. So Dr. Jyoti ma'am, would you prefer to add a gonadotropin right from the start in such cases, considering she's 35 years and she's already had a
No,
spontaneous
for first cycle, at least see the response. Her AMH is 7. We have to counsel her for regarding risk of hyperstimulation, regarding the risk of twin pregnancies, and and our aim has to be a unifollicular growth. So letrozole first 2 or 3 cycles with great emphasis on weight reduction. Her BMI is 29, just to the border of obesity, and add metformin and see for 1 or 2 cycles, see her response. She may be very high responsive. So if we are achieving ovulation and she is ready for IUI, try it for 2, 3 months. If I feel that it is stuck at 12, 14 millimeter, not growing further, maybe 1 or 2 doses of gonadotropin in that cycle.
Yes. Dr. Sulpa, can you just tell us more about this chronic low dose protocol? Because that seems to really work in these PCOS patients and a couple of
Use that
patients.
very often, actually.
Yes.
Yes. So at the age of 35, for a woman who's already been married for 5 years and tried her level best to lose weight, she's in all likelihood coming from a background of extreme stress now. See, there may be some people who are married for 5 years, turn 35, and are not stressed about having a child yet. In such cases, trying with oral ovulagens, 1 or 2 cycles of planned relations is all right. But if she comes and tells you, doctor, give me a child at any cost, then I would not go in for planned relation cycles. Also, there have been a lot of studies that have shown that after the age of 35, ovulation induction with gonadotropins gives far better results compared to using oral ovulagens. Plus, we need to keep in mind that most of the studies that we'll end up reading are unfortunately based on Western women. Indian women do have an ovarian reserve 6 years less than Western counterparts. So, our women at 35 would have the same chances of conceiving as a Western woman would at 41. And reserve starts declining much faster. Although there are, measures to check the quantity, antral follicle count, AMH, but we can't assess the quality, and that does decline very rapidly, especially in with PCOS. So if I was to handle this case, and if I would start IUI directly, I don't think I would do any more planned relation cycles at 35 or after that. One cycle I might use oral ovulagen, maybe in combination with gonadotropins. And then if that didn't work, second cycle, I start very often with, like you mentioned in this slide, 37.5 units of recombinant FSH. And we get a very beautiful, very controlled response, where in most cases, we don't land up with more than 1 or 2 follicles. And the endometrium is much better as well.
Exactly. It's a monofollicular development which we get. And, we have seen cases where even at the 24th and the 26th day also patients have ovulated. We have to just have patience in these patients and keep on doing the follicular studies. Maybe by 24th or the 26th day of stimulation also they end up having a ruptured follicle and they end up having a good pregnancy. Professor Roy,
Hi
what about
Rupali, hi Saryu.
Hi, Desh, welcome on
I
board.
would like to agree with Sulbha here that 37.5 Rec FSH is a fantastic combination to start with, because people who generally do IUIs or who do fertility, who are general gynecs and not fertility gynecs, start 75, 150, and that's when you get the fear of OHSS. And that too, people start HMG. I don't know, there is this innate fear of Rec FSH that people have because people don't use Rec FSH so often. If you see common gynecs, everybody use HMG. And
Because
HMG also
FSH
with the pharma
expensive.
company who's pushing an HMG, probably
Rec-
that. So we need
yeah,
to see which drug you're using, what is the quality, how is the batch, and then start with
yeah,
37%.
but
You'll get a good response.
let's accept that Rec FSH and HMG cannot be compared because economically
Yes.
it is very, very straining to have a Rec FSH to be started on any patient. But if money is not a problem, then it is low dose FSH. According to this Professor Roy Homburg and Colin Howells, it has an equal, it's rather having a better effect. So when money is not a problem, I think rather than wasting patients' time, because today's world, everyone is in a hurry. If you don't give results, they move on to the other doctor. So if money is not a problem, why not start them on a low dose gonadotropins and
Yes.
give them the result?
So 6 cycles of HMG versus 2 cycles of Rec FSH, I think the cost comes out to be almost the same.
Yeah,
Honestly speaking.
At what your HMG of 75 or 150 achieves, like you said, sometimes the stim goes on for 20, 21 days. With 37.5 of Rec FSH, the dose is lesser, the duration of stimulation required is also lower. In spite of all the Cochrane database reviews and everything saying that the efficacy is equal, in practice, we find that there is a difference. So the cost works out to almost the same because the doses are lesser, duration of stimulation is lesser.
absolutely. So that is a very nice thing that we have a monofollicular development also, a low dose gonadotrophin. Metformins also can be added to gonadotrophins to improve the this. So we move on to the next case. So we have seen here now first case, which was a very simple PCOS patient walking into the clinic. The second one, which we saw the case where, the second line treatment was done. Now, we all know that the first line would be a weight reduction, lifestyle management, Letrose, clomiphene. Second line, we saw that they were gonadotrophins. The third line would be definitely an IVF or an Iicc for this patient. So now she's a 38-year-old. She's a known case of PCOS. She's having 5 failed IUI cycles. Previous IUI cycles, whenever she did have 2 mature follicles, good ovulation induction, everything. BMI is okay, 24. Semen analysis normal. Scopy is done and patent tubes. AMH is okay, 8, which is expected for a PCOS. LH is high, 9. Her antral follicular count is good. She's into regular exercises. She's done all the first line management. Everything has been done. After 5 failed IUI cycles, if a 38-year-old patient with an AMH8 walks into the clinic, would you do a IUI again for this patient, thinking that no, these 5 IUIs have been done at some other place and let me give her a good try? Or would you counsel the patient to go directly for an IVF-HC? Anyone can take this question.
IVF directly. I mean, with failed IUI cycles, like I mentioned with the previous case also, stress levels are likely to be very high. If you see the AMH is very good, but somehow the antral follicle count is not that good. If it is 3 to 4 in both ovaries, means it's a total of around 6 to 8. I go more by antral follicle count than I go with AMH when I'm deciding line of management and doses to start with. So in such a case, I would not do any more IUIs, directly IVF.
Okay. And Dr. Siddesh?
Depending on what the patient's mental state is, there are people who are so frustrated that they just want a new perspective. Maybe I would consider an IUI depending on where the IUI has been done, what is the pre-wash, what is the post-wash, how the sample was processed. Maybe I'll give it a shot myself, considering tubes are also patent. Like I recently had a pregnancy for a 39-year-old with 6 failed IUIs who came to me for an IVF. I said we gave it a shot, and she conceived in the first go.
But
So
if I think Dr. Siddesh, if the AFC count was a little better, you would have still thought of a repeat IUI.
yeah,
But I would not go for an IUI considering her AFC is less.
And
AFC,
she has received gonadotropins in all
yes,
previous IUI cycles. That means it
yes,
was costly also. Now
yes,
again, one more IUI cycle with so much of cost involved. Better go for an IVF, which will give better results.
yes, that's it. Now, if we have decided now for this patient that we are going to give her gonadotrophins and we're going to go for an XC, so what would be the gonadotrophin dosage and how would you come to that? This patient, on what criteria or what basis you decide the dosage for this patient? Any one of you, whoever is practicing IVF, can take this question.
On 2 aspects, I would decide which gonadotropin. Ideally, I find in such cases they respond very well to a combination of Rec FSH and HMG, but only in cases of quite a non-affording patient, I would use HMG alone. Otherwise, the combination works very well.
So for all PCOS patients who are presenting like this, would you always add an HMG?
No.
Or only if she's about 35 years?
who are presenting like this with such a low antral follicle count, yes, I would add an HMG, because with a low ovarian reserve, addition of LH has shown to give better results than using FSH alone. Even in cases of FSH PCOS where we expect the endogenous LH to be high, still adding exogenous LH during stimulation gives a better response compared to using FSH alone. Only in younger PCO patients with a very high antral follicle count, I would use a protocol that is only FSH. Otherwise, I would prefer to add a small component of HMG as well.
Okay. And is there any preference which you have for any gonadotrophins as such, or all cases you use REC only?
No, I mean, like if it is a 38-year-old with a lower antral follicle count, then as I mentioned, like FSH plus HMG. In younger patients, in fact, they respond so well to recombinant FSH at smaller doses compared to using only HMG, where the dose required would have been higher.
Dr.
I think I would also stick to standard dose and not either increase the dose too much or decrease the dose too much. Maybe 225, 75 would be an okay average start for this patient, frankly speaking.
Okay. Dr. Rachna ma'am, she's there, or can I have her? I think she's lost contact. Okay, so would you prefer to add antagonists to all the PCOS patients?
We do prefer an ANTAG protocol in all PCO patients. In fact, for all patients, I have not used the long agonist protocol, I think, since 2009 or 10 now, but especially for PCO patients, because then that gives us the liberty of using an only agonist trigger if required, and really helps to minimize the incidence of OHSS.
Okay.
Even
And the
I have
cost.
results with ANTAG. Very, very good results. It shortens the time also, and you are more in control. So I
Less
think reaches 4 meters, I also like to add ANTAG.
And having OHSS is a very, very scary and dreadful thing. Best to avoid it.
Yes.
Because
We
this
can
is not a
avoid
very obese patient.
that time.
AMH is high, very high chances of going in OHSS.
Yeah, so Siddesh, can you tell us with the ANTAG which protocols we have fixed, flexible?
So you could either use the fixed protocol or you could use the flexible protocol. Fixed protocol is, the moment you reach your day 6 of stimulation, you start your antagonist. Or flexible protocol, I would probably not take 13. I would probably take 14 as my cutoff. I wait till 14 millimeters before I start the antag. Serum E2 levels also, frankly, I don't do on a regular basis. But then Cetrorelix is my go-to drug that I prefer because pre-filled syringe, easy to administer, cost is fine. So I generally prefer the flexible protocol where I see 14 and then I start. But then it is case to case basis. You can't actually fix up a protocol for all
Yeah,
patients.
exactly. Do you have any patients in mind when you go for a fixed or a flexi protocol, or it's just like whatever comes to your mind? How do you have anything, or it's like I always follow the fixed protocol? It's that way.
No, 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 no. It is definitely case to case basis. You scan the patient on day 2. I don't directly call the patient on 6th, 8th day, 9th day. I probably call the patient once again on day 5, day 6, day 4, day 5 at least, to then take a decision whether I'm starting antag on the next day or probably not starting antag.
Okay. So we have this picture of a Sono AVC, so which is an automated, 3D sonography where we do. So do you consider doing this for all your patients who are going for IVF ICSI, Dr. Silpa? Or
No,
do you go for a 2D sonography?
just a 2D sonography. I don't do the sono AVC.
Sono ABC. So anyone who thinks that Sono ABC has an edge over the routine sonography, because Sono ABC, we know that it's a color codes each follicle and it takes X, Y, Z, all diameters together. It gives us the volume and everything. So we are more
Maybe one time we can do it, but not for monitoring or anything else. Just for baseline if you want
exactly
to do.
as we come close to the ovum pickup. Do you think that this doing Sono ABC, we are more prepared that how many follicles are there exactly where? Does it have an edge over the routine 2D scan? That's what is my question.
If you're doing the 2D scan yourself, then that's the best thing that you can do. If you are getting it done by a radiologist or by somebody else, then maybe you require a bit more information. But if you have scanned the ovaries yourself, then I think a routine 2D follicular monitoring is more than enough information.
Yes.
Okay, so that was a Sono AVC image on date 8th of the patient. The same patient I had given gonadotrophin 225 and HMG 75 was given. She was started stimulation and ANTAG was started on day 6. her E2 level on day 7 was done. It was normal in 3000s. But, when we went ahead on day 11th of stimulation, we saw that the E2 suddenly went up, shot up to 15,376. Now, in such cases, in spite of giving ANTAC, the E2 level went this high, and it was done from a reputed lab. So we didn't even have the discrepancy of the labs. So in this case, I want you to tell me which is the trigger option which you would consider and why.
GnRH channel lock trigger, definitely, because we know that HCG trigger predisposes to OHSS, a very, very high risk of OHSS in this patient if HCG trigger is used solely GnRH agonist. And the use of GnRH agonist trigger and a freeze-all is the best way to avoid OHSS. Apart from that, we do, advise her to take plenty of oral fluids. We call her for monitoring after the pickup also 2 days later or 3 days later. And we can add dopamine agonists such as cabergoline.
Cabergoline.
Yeah,
Yes.
so one more question, Dr. Sulba. If this, when do you do the estrogen levels in the serum estradiol levels when you go for this stimulation, or do you do it? Because nowadays, I have seen many IVF cycles, they do not do the E2 levels.
When I do the E2 levels, if I see 20 or more follicles on ultrasound, otherwise I don't do it.
And suppose this E2 level had come to 10,000, is there a cutoff where you decide that no, in this patient, I'm not going to give the HCG level? So is the cutoff based on the E2 level or on the sonography which you see?
Both. So if I see 20 or more follicles, or if the E2 is more than 4,000, in both these cases, I will absolutely not use an HCG trigger and prefer to go with the GnRH agonist trigger only. IVF or fertility procedures are elective procedures. There is absolutely no excuse, not justified, to have a woman end up with the most dreaded complication, which is OHSS. 20 years back, we used to see women ending up in ICUs, but in today's day and age, we all pride ourselves in having OHSS-free practices. So definitely no HCG trigger. If the cutoff I take is 20 follicles on the day of trigger that are ready, that is 20 or more, or a serum E2 of 4,000 or more than that.
Yes. And
I think the law does not want us to cross 7 follicles, so we need to monitor more frequently and prevent getting to that stage, honestly speaking.
yes, so because this patient, in spite of giving a GnRH antagonist, she ended up with having a really bad, not an OHSS kind of a picture, but it was a mild OHSS for sure. So if this patient was not, had not gone into an E2 level, say it was E2 level was say 4,000 or something. So in those cases, what would be the trigger? Would you go for a duo stim?
A duo stim or a
dual trigger?
Dual trigger.
Even HCG as well as a GnRH.
I prefer to use that only if like the cutoffs have not exceeded, and especially if there is a discordant growth of follicles. Otherwise, if the number of follicles is less than 20, E2 is less than 4,000, and I'm planning a fresh transfer, then I prefer to use recombinant HCG alone. If it is more than that, then GnRH agonist alone. If it is less than that, but a discordant growth, that is where I use a dual trigger, because in some studies it has shown that that gives higher number of M2 sites.
As we all said that, Dr. Jyoti ma'am, can you just tell us what could, suppose this patient lands up in an OHSS. So what would be the preventive measures which you would think of? In spite of taking all the precautions, sometimes it happens that, we know that ANTAC cycles, we do not have an OHSS, but sometimes they do go into it, even if it's a mild OHSS.
So we have to explain her what has happened. This is due to the procedure that the HCG in her body has increased, and that has led to what to expect. So she may have little pain in abdomen, little nausea, little bloating, and she has to drink a lot of water. She has to come to the clinic every 2 to 3 days, and if we have to monitor the abdominal girth, size of ovaries, fluid collection, CBC, and we, as I already said, we can start her on capgolin. There are no other very evidence-based medicines, but still we can continue with metformin and also give her calcium, but it is not proved to be very useful. And then keep her on, take her parameters, the CBC, coagulation profile, and keep her hydrated. If it is mild OHSS, it can be treated at home. And if it crosses the mild, if the size of ovary grows beyond 8 to 12 centimeter, then we may think of admission if a condition worsens, like if her PPAC cell count increases, the coagulation profile distorts, or if there are any signs of liver or renal injury, then we have to admit and treat the patient.
So on the day of on the day of ovum pickup also, once we have done with it, I think we can put her on AV hydroxyethyl starch, HES we can give and immediately put her on a Capgol.
Yeah.
I think we should also not forget protein supplement, because if you have a vegetarian patient and the
diet.
protein is very less in the diet, at least add a protein supplement. Tell her to take twice a day, thrice a day also is okay, because our diets are absolutely nil in protein. Unless you're like actually consciously taking care of your protein in the diet, then it is a little difficult to manage the protein supplement.
Actually, high protein diet once we start the stimulation, that time
Yeah.
also we start telling her every day, eat protein, eat protein, eat protein, so that.
Very long back, 20 years back, I think I had seen a patient with ascites and all those things. So we called a physician, and I think we had given the patient an albumin drip also.
Yeah.
So it was very long back.
Low molecular weight heparin, albumin, supportive care, IV fluids, everything if the condition worsens.
A little bit of tapping, and we done all those things. So it can sometimes,
None of the infertility specialists would want to think also of.
No,
Because
that
this
was
patient,
25 years back.
did land up with a little bit of severe pain, nausea, vomiting for 2 days. And I had started everything for her, but somehow within the third, fourth day, she settled, and I thought things were going out of hand. But luckily, fortunately, everything settled and she was all fine.
So if early OHSS happens, it will settle usually around 7th day.
Yes,
if
but
we have transferred and she gets pregnant, then
yes, but the
problem.
second day of ovum pickup, patient calls and says, I've got vomiting 3 to 4 times since morning. And then you have your radars full, like now, now it's going to be bad. You start thinking real bad things. Yes, so that was a very nice case discussion. Thank you all for all your great inputs. We have a couple of slides where Dr. Sharayu will take over. But this discussion was really good. Thank you so much.
So we spoke about the whole spectrum of ovulation induction and the different drugs. What is the role of ovarian drilling in all of this? When do you do? What are the indications? Anyone can take the question.
Ovarian drilling only and only if it is like considered a second line of treatment when everything else, the first line of treatment completely fails. And in case you are doing a scopy for something else, then you can think about it. But as such, ovarian drilling is more or less obsolete in today's day and age.
Yes, so best indication would be if we're anyway putting in a scope for something else, we do
a
it.
very lean patient with high LH. She has lots of signs of hyperandrogenism. And when you see the ovary on ultrasound, there is very dense echogenic stroma with vascularity. This is the patient. She will respond good to laparoscopic ovarian drilling. And maybe if she lives far away, she cannot come for frequent follow-ups. She wants to try for natural pregnancy. Then we can think of this set of patients will respond well, because there's a very less scope of weight reduction and metformin and all that for them. And if they have high LH, high hyperandrogenism, and very big ovaries with very thick echogenic stroma, those patients are ones in whom you can think of ovarian drilling.
Right. In them, the ovulation rates will increase only with the procedure.
So this question would be to Dr. Sulbha. We know that IVM they are saying it's a future for PCOS patients. Can you elaborate on this just a little small?
The premise is very promising indeed. If you can extract the oocytes without really having to stimulate for the entire 10 or 11 days, and then in vitro they are, taken to the mature state, then that absolutely prevents any and all risks of stimulation with these women. It is still, though it's been around for a long time, it's not been universally practiced yet. So I think we do still need to wait for, more studies to come out to tell us there is also concerns about epigenetic effects on oocytes and embryos, the more that they are handled and cultured in laboratories. So pros and cons need to be weighed. I think the way stimulation is being practiced currently for PCOS patients we are by and large managing to, eliminate the risk of complications such as OHSS. And that could be one of the reasons why IVM has not yet taken universal acceptance.
So maybe, where we want a low treatment cost, maybe later on in life, whenever you think of using an IVM, so things will really look forward. Can we have a take-home message in all these three? We have tried to bring about from a simple PCO patient walking in our clinic to another patient who really wanted an IVF. So clinical scenarios, most of the things, whatever knowledge we could extract from all our panelists and give to all the audience, we have tried our best to do that. And it was really a very nice live interactive, very, very good thing. But we would want to hear from all of you some few
Ma'am,
take messages. Yes,
I think Archana ma'am wants to sum up.
yes. Yeah, we just take our take home messages from this and then ma'am can take it from. Yes.
I would like to start by saying that people still think that PCOS is a temporary thing, but I keep telling them this is a lifelong problem and it's not going to go. There will be remissions, there will be exacerbations, but it is with you for life. So it is a lifelong working process. You have to work on it.
Yes, Dr. Sulba.
Yes, I absolutely agree. We do have patients who come and tell us, can you get rid of the PCOS? The rest of the things I will manage. Or they come and tell us that I had PCOS, but now we don't. It's very important to educate them that it is fairly common, commonest cause of hormonal imbalance in the reproductive age group. But now it is more and more recognized that it's not just reproductive repercussions, it is a metabolic syndrome, and they will have metabolic problems almost 5 to 7 times higher risk as they grow older as well. And that's why it is a holistic treatment that needs to be done. As far as fertility is concerned, as we have discussed, first line of management is lifestyle with weight loss with the help of diet and exercise both. As far as stimulation is concerned, yes, as this slide says, clomiphene is time tested. In fact, a lot of practitioners still prefer it over letrozole because letrozole in the middle had a lot of concerns about teratogenic effects. And even though that has been dispelled, there are still institutes and practitioners who are not completely convinced and would prefer to use clomiphene over letrozole. The guidelines seem to suggest that
Right.
is the first line of management. Adding metformin, I feel that it does have advantages for ovarian stimulation as well. Both the extremes, that is having resistant or having a hyper response, are kind of nullified when metformin is added. It does help with weight loss, and which itself improves their quality of life. Women with PCOS have a very compromised quality of life, and weight loss helps with that. Gonadotropins, second line of management. As the woman's age increases, even though the AMH and the antral follicle count look very promising, we need to keep in mind in background there is a deteriorating quality of oocytes as well, and therefore deadlines need to be kept in mind. If a few cycles of planned relations haven't worked in stepwise fashion, we need to guide them towards more advanced treatments like IUI and IVF. In all cases, we must make sure that side effects or complications such as OHSS are absolutely eliminated, and also, in fact, multiple pregnancies. I often tell my patients that the risk of multiple pregnancy is higher with IUI because we cannot control how many will ovulate and fertilize. IVF, from that point of view, is more controlled and therefore more risk-free.
We go to a lot of schools, try to catch girls in the younger age and educate them for physical exercise, to reduce junk food, to reduce screen time, because that is the age where you can actually address the problem. Even the young girls who come for menstrual irregularities, we involve the whole family. Tell them that you are having this, you can see this problem because you're having delayed cycles or whatever, but your brothers, other family members will also suffer if the same lifestyle, same diet goes in the family. Maybe they will have metabolic derangements at 30s or 40s. So the whole family has to be educated and involved in the management of PCOD. That will help not only our patient but also the in general her mausi, bua, mother, all first, second degree, all relatives should be educated about this.
Dr. Siddesh?
I think I'm on the same page as Dr. Shruti Madam that we would rather target the younger ones to schools, teach our children the importance of diet. Tell them junk food, what is junk food and what is not, because they will be the 20-year-olds who will suffer from PCOD at some point of time. And PCOD is real. It is not a myth that most people on Instagram feel that हाँ ये तो कुछ भी है. There are people who still dismiss this whole entity. Also, if you see the crowd that come for fertility nowadays, they have so much knowledge in their heads that they think they know it all. We have to tell them that yes, this is a physical problem, a hormonal problem which needs to be. You cannot say denial that this does not happen to me. I am so thin, मुझे नहीं होने वाला है. This can happen to anybody, and it needs, as Dr. Sandhya said and Dr. Sulva said, it is a lifelong effort. It is not going to go away in a day. Even if it goes away, it is going to keep knocking at your door like those villains in the Hindi movies. They have to be kept at bay at all times.
Yes, very true. It's like the Gabbar Singh of Gynac, we can say PCOS.
And I think when we explain and when we're counseling these young girls, if we tell them about the long-term consequences of PCOS, like hypertension, diabetes, depression, and all of these, that really helps in convincing them for taking all these corrective measures.
Yes. Yes. So I think Dr. Shashank Shekhar is there in this.
No, he
I think
left.
he
He
just
has left.
left.
Yes, Dr. Achana is
We
also.
Rupali, we are just working on even PCOS and this, mothers who have sons. So we are working on that aspect also now, and we've come out with an impact course on nutrition, which we are doing along with the SNTT University, which is targeting schools, colleges, everything. So it is coming in a big way. I'll share the details with you all. But now even boys, we are looking into it. It's not just the girls, mothers who have PCOS. So the repercussions which happen in the, like college age group.
This is a very different aspect to our
Yeah.
PCOS. This. So I pass it over to Dr. Archana Baser, ma'am, now that we have. Madam?
Yeah, thank you, Rupali, for really moderating and steering this PCO panel in the right direction. I know it's a very difficult topic, and it is very tough to talk to the patient and of the PCO and when they come diagnosed with PCO. And I think what is very important is like everybody has given very good carry home messages. One thing I want to say that there is a lot of hand holding is needed in PCO girls, because many of them, like today only I had a girl, they come from hostel, they live all alone. We have to talk to them about all the metabolic diseases and all, but not at the first consultation or first meeting, because otherwise it will have, I don't know how they will take it, whether we cannot give too many informations or too many things in the first meeting of the PCO, because that may really depress them or that may put them off. So it's important that we get to know the patient first before we really talk to them a lot. When they come for infertility, they are already married, they have a partner. So that's a totally different thing. But when it is young women, we have to give information with caution. That's the thing which I want to say. And I really thank panelists, Dr. Siddesh, Dr. Sandhya, Dr. Sulba, Dr. Jyoti, for really giving good insight into the topic. And Rupali and Shariu, you really did a wonderful job. And my young girls, both Akriti and Ditya, they really, called up everybody, made it sure that everybody connects and join in. And I would like to thank the format and especially Mr. Sudeep for really giving us platform and giving us a seamless um, working of this platform. So Rupali, anything you want to say, or then
No,
we can
I'm
just
I'm
wind up?
very happy, ma'am. Thank you for giving us this opportunity to conduct and moderate this panel, because being a general gynecologist as well as managing my own infertility patients, many questions which I have asked must be lying in the minds of many of the other gynecologists also, who are not into an active IVF practice, but definitely they face with these dilemmas every now and then. So we try to inculcate those normal specific questions, and that's why we didn't go into the embryology or the lab aspects of IVF and ICSI. Probably maybe we can later series we can do an advanced IVF, and you can rope in all the IVF from all the zones and then have a nice interactive session on that. Thank you all the panelists, because you all have been wonderful for joining in spite of all your busy schedules. We can see that a couple of panelists were not able to join because of obvious emergencies or inevitable reasons, but maybe next time we can always catch up. And can we have a word from Dr. Suchita ma'am also, if she's there, and Dr. Jyoti Unni ma'am, if they are there still?
Yeah, I'm still here. I don't know about Suchitra. Yeah, thank you very much. A lot of learning because, as I told you in the beginning, I'm really not too much into infertility, but we do see many patients who have had assisted reproductive techniques one way or the other, or those who come to us initially with infertility, and of course, many PCOS patients, as all of us are seeing now as the numbers grow. It's good to have insights into this, because sometimes they just come for a second opinion or for a little bit of counseling, or they've known you for so many years that though they have gone into ART, they want to come and just hear from you that what they're doing is right. So it's good to learn all these things. Thank you so much for a very insightful webinar.
Thank you, Dr. Jyoti, for
Thank you.
staying with us all through.
Thank you so much, Dr. Suchita ma'am, Dr. Jyoti Unni ma'am, to all of you, Dr. Priya ma'am, everyone who have been here and who have been supporting this. And, thank you, Archana Basel ma'am, for being this series coordinator. So we are looking forward for many more such webinars where we can be the faculty, delegates, etc. We are very happy to be of any and whatever help we can. Dr. Akriti and Ditya also, you all were very good. Thank you so much, Sharayu. And with this, I think, ma'am, we can end this here.
Yes, yes. So bye for
Thank
now.
you.
Stay
Good night.
connected and meet again. Yeah.
Yes, ma'am. Yes.
Okay.
Thank you,
Bye-bye.
everyone.
Thank you.
Bye.